Okay, hello everyone. Welcome back. Welcome Dr. Parajuli. Welcome Dr. Khan. And it's so nice having you all over here. I think we're still waiting for people to join. First of all, really truly welcome back because I think this is the longest we've been away. I think the last webinar we had, God, was at, I think it's the end of June. So, it's been quite some time, but I hope you all had a very successful exam session. And I hope you guys are enjoying your summer or, studying for research if you have any. And yeah, no, I hope it was a ball. So today's topic is actually quite a passion project for me. And it's about management of medical records. Now, when I say it's a passion project for me, it's not because I know particularly a lot about it, but I think growing up in a medical family, I've always had people venting about the paperwork, about the documentation and those kind of things. So, it's really a huge thing in medicine. So first of all, let me introduce myself. My name is Mohsen Salim. I am a final year medical student studying in Plovdiv, Bulgaria. Today I have with me Dr. Raza Khan, who is a graduate from the same university, dental graduate, and I have Dr. Arun Parajuli, who will be our keynote guest speaker today, and he will be talking about the topic. So just before we get started, I'm quickly going to go over today's program. So we're punctual over here. So we're starting on the dot. And this is my little 5-minute welcome. And then we're just going to hand it over to Dr. Parajuli. And then afterwards, after we will have a short open Q&A. So what I want everyone to do during the webinar is just fill up the Q&A at the bottom with all kind of questions, whether they're relevant to today's topic or just in general, you guys want to ask Dr. Parajuli anything. So Dr. Arun Parajuli, let me just give a quick introduction. So he is academic foundation. He's in the academic foundation program. My brother describes him as a genius, but he will obviously disagree with me. And I've worked with him before, and he's an excellent speaker. He's working in Glasgow at the Queen Elizabeth University Hospital and has an interest in anesthesia and something else as well, but great things going for him. And so yeah, definitely hit out with questions because this is a golden opportunity for you. So fill them up. And at the end, what I will do is I will direct the question to Dr. Parajuli myself, and we'll try and get through as many as we can. Just before I hand it over, I also want to give a big thank you to our partners, Lectorio. So Lectorio is an all-in-one study resource for medical students that combines learning science and medical education into one easy-to-use platform. Now, I'm sure you guys have heard me say this every single month for so long. The funny thing is, I just had my exams and I was using Lectorio back-to-back for each and every single one of them. And it really did help. So even if it was just light revision, even if it was going through something, even if it was in the evening when you can't really be bothered reading and you just want to hear someone speak, that makes sense. So Lectorio is really good for that. At the end, when you fill in the feedback form, you will get emailed to you certificate for attendance and also a 50% discount code for Lectorio, which you can apply on their website in the next 24 hours. And we will also be handing out some free passes. So I think once you fill in the feedback form, we just pick people at random and we contact them. So yeah, I'm really excited for this one, and I'm not going to wait any longer. I'm going to hand it straight over to Dr. Parajuli.
I just want to start off by thanking you guys so much for giving me this chance to talk about medical documentation. It's an area that I think is really important. And I think that if you've not worked in the NHS before, if you've not worked in the UK before, particularly if you've studied abroad, but even if you've studied in the UK and you're just getting started working on the wards, it's a big topic that you don't really get taught that well in medical school. There are a lot of variations locally in terms of how things are documented. Places will have electronic records, or they'll have paper records. They'll have electronic prescribing or paper prescribing. They'll have pro formas that vary from place to place. But the bottom line is there are some key principles that underlie how doctors should approach record keeping in the NHS, and we'll go through some of those things, and hopefully it'll be useful. Certainly, the General Medical Council is not an organization that is free from criticism, and I don't know if people have been following in the news. There have been a lot of criticism leveled at them in terms of how they've approached cases against doctors, and particularly ethnic minority doctors. But the reality of the situation is, if you want to work and be successful and provide the best level of care for your patients in the UK, you need to know what their guidance is going to be, because they are our official regulatory body, and you need to understand and abide by their principles if you want to do what's best for patients and keep yourself out of trouble. So what does the GMC say about documentation? Well, I think the main point that you can look at is what they say about continuity and coordination of care. So the reason that you document things is so that continuity of care can be provided. So the next chap, the next person that comes along knows what you've done for them, knows what's happened, knows what your plan was, knows what you've said to the patient, what you said to the patient's family, what history you've taken, what information you're going off. It's impossible to have continuity and coordination of care over time and between specialties without good medical record keeping. And being as anonymous as possible, over the last year, I've seen situations where very senior medics have come under criticism where they've done the right thing, or they've done something entirely reasonable, but they've not gotten into any official trouble, but been criticized by their peers and their seniors for failing to document what they've been told, what they've done, and the information that they're using to make decisions. Because you can make the best decisions in the world, but if you don't document why you've arrived at those decisions, people that don't know all the details and are skimming things can very easily draw the conclusion that you're incompetent because you haven't outlined that something is your impression or your plan. So when you're documenting, you need to share all the relevant information with colleagues involved in your care. You need to be able to hand over information effectively, and documentation is an important part of handover. And when you delegate care, or whether you refer patients to other specialties or to allied health professionals, you need to be able to say, this is what I've planned, this is what I understand, so that other people can go through documentation and provide their input and their expertise as well. And this is, I'll also highlight the point of capacity and vulnerability, particularly when you're dealing with a patient who lacks capacity to make a decision, or who may be clinically or socially vulnerable in a particular way. You are definitely opening yourself up to criticism if you don't document very clearly what you've done, why you've done it, and the basis under which you've performed a certain procedure or arrived at a particular decision. So I want to try and make this as interactive as possible. Do these basic principles make sense to everybody? That we rely on good medical practice as our basis for documentation, and that good medical practice puts good documentation at the core of continuity and coordination of care. Does anyone have any questions about what that really means in practice?
Okay, Dr. Parajuli, I just want to say,
Yeah.
we don't have a chat box, unfortunately. So
Okay, I
you can
see.
ask questions right now, or what
Fair
you
enough.
guys can do is take notes of the topics you might want Dr. Parajuli to go back over, and
Okay.
write them in the question at the end. We can go over them.
Yeah. Okay. Grand. So just to sort of summarize this area, I think the key things are, anytime that you see a patient, you need to document any relevant elements of the history that you get from them that justify your decisions, You need to justify what your impression is of what's going on. You need to document what your plan is, and certainly, ideally, you should document whether you have or haven't personally completed elements of the plan. And parts of that will also involve using electronic health systems. So, for example, if you click off that you've seen a particular result on an electronic lab system, that is documentation. If you click off that you've seen a scan, that is documentation. But the key thing is that to ensure continuity of care, to ensure full candor in your understanding of what's going on, you need to document effectively. Okay, so the next couple of slides are just going through some forms of documentation that you might see if you ever end up working in a hospital in the UK. This is a clerking document. I don't know how many of you will have seen these before, and this is very kindly been taken from the Great Western Hospitals NHS Trust. When you come in and you clerk a patient in acute receiving, often they'll have been seen in A&E. An initial plan will have been made, they'll have been stabilized, and then if they need admission, they will go through to the acute medical or the acute surgical unit. And often there are these formularized, or rather formulaic paper booklets called clerking books that are used to form the initial assessment of a patient. So as you can see, this has space for their presenting complaint, history of their presenting complaint, past medical history, and here we have Charleston comorbidities, which is part of an index for prediction of inpatient mortality. And certainly it's not used in GBC, but clearly it's part of the clerking documents for Great Western Hospitals, or was at the time when this document was released. I'll draw your attention to the upper left-hand corner. Now, this is a really important thing that that you need to know when you start working is you should not take any notes for patients that do not have either a patient sticker with at least 2 pieces of identification on it. And you should very clearly document the time when you see somebody, because that may be relevant in terms of the information that you might have. If you arrive at a certain conclusion about what's happening with a patient and a certain lab test hasn't come back yet, you know, your decision-making process could be viewed very differently than if that result had been available to you and you simply did not look for it. So it's very important to document when you see things. It's very important to document your grade, so people, and you know, you could argue that really it shouldn't matter what your grade is, in the sense that if you have done the right things and you've done the right investigations and you've done asked the right questions, really it shouldn't matter what where you are in your training. Well, the reality is, if you're an FY1 and you are deciding to do LPs on your own and order MRI scans on your own, you'll be viewed as acting inappropriately. As much as people like to talk about a flat hierarchy within the NHS, you know, there is a chain of command. It is important to escalate things and discuss things with your seniors, and you should always make clear what your grade is, and be very candid about the limits of your ability. So this is an important thing to document as well. And is there anything else in this clerking document that we need to talk about in particular? Not particularly. Okay, so the second bit of a clerking document will often involve a very basic standard examination. You'll listen to a patient's chest, look at their abdomen. Potentially, you'll do a PR exam if clinically appropriate. You'll document basic neurological findings. You'll document basic cardiovascular findings, and all things that you will have or will be learning in medical school. And then often, as an initial screening test, if patients come in acutely unwell, they'll have a chest x-ray and an ECG, and you'll write down your particular interpretation of the chest x-ray findings and the ECG findings. And in combination with that, with your history, with the initial blood tests that have been taken, And this particular clerking document doesn't have a place for writing in blood tests, but you often do write in the blood tests so the consultant doesn't have to open them on the computer. In combination with all those things, you will write down what you think is going on, and you'll write down the basic plan. And sometimes your plan might literally just be chase bloods, chase ECG, IV fluids, and senior review. Where sometimes, and depending on how senior you are, your plan will be very elaborate. So yeah. But the important thing is, I think a lot of people are scared. Particularly, I was scared when I started working, of documenting what they think is going on. Sometimes you can get away with not really commenting and just saying IV fluids, bloods, ECG, chest X-ray, senior review. But I think it's very important that you document what you think is going on. Uh, and yeah, you might be a bit afraid of looking foolish, but it's far more foolish to work on things blindly without having an idea of what you really think is going on with the patient. And it doesn't need to necessarily be an elaborate plan. It can sometimes be as simple as uh, infection, query UTI, query LRTI. So that's the basic elements of a clerking book, and this will be what's called the post-take review. So after a patient is taken, after they're clerked, after they've had their history taken and bloods taken and the chest X-ray done and the examination done and a differential generated by the F1 or the F2 or the registrar, whoever's seeing the patient, the consultant will come and review these things and arrive at their own conclusion of what's happening. And sometimes you'll be unlucky and the patient will tell the consultant completely different things to what they've told you about what's been happening. But the important thing is that you document what you've heard, and this is a perfect example of it, that you're consistent with what you've documented. And you know everybody's been through that. I'm sure every consultant has been through the same situation as a junior doctor of a patient changing their story, and it can be embarrassing, but what's important is that you've documented everything clearly. This is an insulin prescription chart, another example of a document where not documenting things clearly can get you in a lot of trouble. Areas to keep a particular eye out for: preparation. It's very easy to simply mistake one form of humulin for another form of humulin, but if you give somebody 20 units of humulin M3 that normally takes 20 units of humulin I, you'll have to see a very different result. Typically, you don't put the U at the end of the number of units because that can very easily be mistaken for a 0, and somebody can get given 100 units rather than 10. That has happened in the past. Google it if you want to see some cases. And you should always document your name and your signature next to anything. It's a legal document. It needs to be signed, and you need to be identifiable. You should. If there's one thing that I can say about documentation, it's that you need to be able to stand by your decisions, and you need to be able to justify them based on the information you had, and you need to be able to identify what the things you did were and what other people did were. And simply scribbling an illegible signature and not standing by the decisions that you make is unacceptable. You need to clearly identify all of the choices that you've made. Okay, so that is an insulin prescription chart. Very simple bit of documentation, but very important. And this is an anonymized. This is obviously a fictional patient or a fictional practitioner. A Cardex, so another place where you might document an action that you've done. Here's a prescription for a Parkinson's medication, and you need to quite clearly document the time for each administration, the dose, etc. And it's important that everything is legible and the dates are all clear. And then here we have, so the patient's been seen in acute receiving, they've had their initial clerking, which has all been documented very clearly. They've had their post-take review by the consultant, and then they come up to the ward and they have a ward round review by Registrar Snape. And They document the issues that have been going on. They document the bloods because they've seen the blood, so they need to document that they've seen them. Or if they haven't seen them, they need to say bloods awaited. These are the most recent bloods I've seen. They've documented the OBS. I hope everybody's familiar with news, the observations, national early warning signs, the scale for assessing essentially how off a patient's clinical observations are. They've documented that they've seen the bowel and fluid charts and the diet chart, and they've documented their brief history from the patients and their examination findings, and they've documented their impression, and they've documented their plan. They've written the date and time, and they've signed it, and very conveniently they've put in their bleep and they've put in their GMC number. Somehow they've gone from they've gone from a registrar to an F1 by the end of the page. But point being, or perhaps it's the F1 that's documenting for the registrar here. Point being, they've put their name on it and they've put their GMC number and their bleep on it so they can be approached. And that is actually something I thoroughly recommend to people, particularly if you're going to see a patient somewhere that you don't typically work. Documenting your bleep at the bottom is really useful, because if anybody can't read your writing, they should be able to contact you. Otherwise, you've just wasted your time by documenting, because if what you've written is illegible, you haven't documented, you've just put some ink on a piece of paper. Cool. This is a fluid prescription chart, also an important place for documentation, and it's really important that you document when you want fluids to be given and how you want them to be given, and you document who has prescribed things. I can't tell you the number of times I've just seen 0.9% saline, 500 milliliters, over 6 hours, written, and then written 3 times. And then because no date has been put on it, the patient ends up getting it 4 days later when the document is eventually pulled out of the notes by the nurses, and the patient is now eating and drinking, and you're asked to prescribe more fluids, even though their AKI resolved 48 hours ago. So, yeah, needs to be documented. Okay, so we've talked briefly about the general principles underlying documentation. We've talked about some documents, and I've also been asked to speak a little bit about a complete history. And how are we doing for time? We're about half an hour in. Okay, right. So, Mohsin, I think this would be very, very useful if you and I did something interactive.
Sure, let's go for it.
Shall we do something? Shall we make it interactive?
I'm all yours.
Okay, fine. So, I'm a patient that's come in with a sore head. Okay, so what's the first sort of set of things that you're going to start asking me about my sore head?
Well, when did it start?
Yep.
Were you doing anything in particular when it started?
Yep.
Are you taking any medications?
Okay.
How long is it reoccurring, or has it been going on?
Great. So the first thing is fantastic is questions relating to the presenting complaint. So I don't know if you're familiar with Socrates. Have you heard of Socrates, Mohsin? Yeah. So site, onset, character, radiation, alleviating features, timing, exacerbating features, and then what is the final S? Is the S system questions and other questions in the system? Maybe it is. So you asked me about my headache. I'm telling you, it's in the back of the head. It came on all of a sudden. It's 10 out of 10, the worst headache I've ever had, Dr. Salim. It's not radiating anywhere, and it gets worse when I cough. And it's just been there continuously for the last 2 hours. And I've tried paracetamol and it's not touched it. And also, it hurts when I bend my neck forward. So these are all system-related questions. So these are all questions around, around pain. And then you're asking me about meningism and photophobia. You're asking me neurological system-related questions. So you've done all of those sorts of
Okay.
questions, and then you ask me about a systemic inquiry. So what's a systemic inquiry in your mind, Mohsen?
Well, I'd look at, the type of things that can cause headaches secondarily. So have you been drinking water?
Okay,
Have you eaten anything? Are
okay.
you under, additional stress?
Yeah. So when I say systemic inquiry, what I generally mean is how have you been systemically? So have you lost weight over the last couple of months? Have you had any fevers? Have you had any night sweats? Um, Broad questions about, have you had any issues with your breathing? Have you had any issues with loss of consciousness or changing in your vision? Have you had any issues with your waterworks? Have you had any issues with your bowels? So you're just quickly doing a rundown of all of the body systems uh, to sort of exclude anything out with of that system so that you can focus on any particular questions. And if they do say, for example, if they say, well, yes, I have actually had some fevers as well, you can start doing the same sort of questions related to the presenting complaint for that as well. Okay, so I've asked about the presenting complaint. I've got a headache, no fevers, no weight loss, nothing else. My waterwork's been fine, my bowel's been fine. I've been eating okay. I've just developed this sudden onset headache in the back of my head, 10 out of 10. And I've got neck stiffness and a bit of photophobia as well, actually. Okay, next bit, ice. Have you come across this before?
Ideas, concerns, expectations.
Yeah, exactly. Perfect. So, uh, so ask me what I think is going on.
So what do you think is going on, Aaron?
So I really don't know, but I'm pretty worried because I have a brother that also, had a really bad headache and turned out he was having a bleed in the brain, and he died actually. So I'm very worried. So here the patient's giving you their concerns by themselves, and that's often the case is they'll give you the concerns, um, and expectations. Sometimes it almost sounds a bit ridiculous when somebody says they think they've got a bleed in the brain to ask them like, "What do you want me to do about it?" But sometimes it's a bit more relevant. Sometimes it's a bit
Could
something
you
that yeah
fit in like when the patient starts demanding certain tests into
yeah
expectation? I need a CT. I definitely need a CT.
yeah. So what I'd say is that is probably a expectations. Sometimes patients will present their expectations. Sometimes they'll say, I want a CT scan. And in this patient, I think that probably is clinically very appropriate.
Yeah.
But sometimes they'll want, for example, a CT scan when it's not clinically appropriate, when they've had headaches on and off for 5 years, when they're stressed and when they don't drink enough water and they take, sort of 10 paracetamol a day and, you know, um, but it's important to at least elicit that, and you can start to approach
Yeah.
uh, perhaps dealing with unrealistic expectations, and that can be very challenging later on. But it's important to at least understand what a patient's
How would
expectations
you
are.
combat that in turn of, let's say, a patient comes to you with something outrageous, like I definitely have a brain tumor.
Yeah. So I mean, well, I think it entirely depends on the situation. It entirely because there's a range from I have a family history of cancer, and I have a medical symptom that's called explainable by another organic disease. For example, I have a family history of bowel cancer, and I am having what's most likely a flare of ulcerative colitis, and I'm worried about bowel cancer. That's one thing. Uh, Versus my tummy hurts a bit, and I definitely have bowel cancer. Versus, um, so that would be more towards sort of, um, health anxiety versus patients with medically unexplained symptoms, sort of, somatization versus patients that are actively malingering because, for example, um, they want time off work and or whatever else. There's a wide spectrum of different patients that expect investigations for things that may or may not be appropriate. So I think it hugely depends on the individual situation. The key thing is to try and understand why a patient wants something, and to enter into it, a negotiation to help them understand why you see things the way you do. And I found the most useful thing has always been for me to say to them, well, I understand that that's why you're concerned. But this is why I feel the way I do. And I remember a conversation I had with a family member who was very, very upset because her father, who was a 65-year-old man with COVID, was exhausted on day 8 of COVID. And he wasn't on any oxygen. He didn't have any other features of severe disease. He didn't have chest pain. His inflammatory markers were settling and he was improving. Um, but she insisted that something was deeply, deeply wrong with this patient. And the thing that settled her was explaining to her, well, if this were off, we would do this. If this were off, we would do this. If this were off, we would do this. And being honest about the limits of your knowledge and being honest about why you're making decisions and documenting all of those things, I think is really important, because patients and patients' families will expect things from you that you don't necessarily think are the best thing, and you don't have any obligation to offer somebody something that you don't think medically is in their best interest. In fact, it would be unethical to subject somebody to an invasive investigation that wasn't clinically appropriate, just to make a family member
Well, if
happy.
it's a harmless investigation, say for just the peace of mind of the patient.
Well, so I mean, it depends. Again, it depends hugely if it's a question of if it's something that is medically appropriate, um, then fair enough. You can justify it, and you can justify it in terms of reducing the anxiety of the patient. But there are a lot of investigations that are not harmless. And what if it reveals something borderline? What if that CT scan picks up an incidentaloma? CT is a bad example because it's associated with radiation, and that in itself has a certain degree of harm. But say it's an ultrasound scan that's not clinically appropriate, but it picks up something that's a bit strange, and then that leads to a CT scan, and then that leads to a diagnostic laparoscopy, and then that leads to a DVT and a death in a 25-year-old. So it's
Bunny hole.
it is it's a rabbit hole, yeah. But I think the key thing, and there will be people that are far better at dealing with these things than me because I've only worked for a year. But the experiences that I've had have been that if you're honest with people about why
I
you
think I see this so much, especially in, well, I'm from an Asian culture, but you'll always get people going on about, oh, go to that doctor, he'll give you the test you want.
I mean, that is the thing is the reality is we in the NHS it's a health system that is free at the point of use, and I think should remain free at the point of use. And we as doctors have an obligation to work in the best interests of our patients. They're not our clients, they're our patients. They're not people that are specifically paying us to do things for them. And I think that is the issue with a for-profit health system, is that
Yeah.
An NHS doctor will never do an unnecessary investigation, and also they lose nothing personally most of the time by doing an investigation. By requesting a scan. So anyway, you can make arguments that actually a poor salary health system disincentivizes doctors from doing anything at all, because why would a surgeon want to do a surgery if they get the same salary if they do or they don't? There's been extensive research into this, and I'm certainly no expert. But bottom line is, I think it's important that you justify to patients why you're doing the things that you do.
Absolutely.
And you should be able to point to where you've documented and say, Mr. Jones wanted a CT head. I explained to him that I didn't think this was appropriate for these reasons. He was upset. I understood his frustrations, but this was the decision that was made. Okay, so you've talked about their headache, questions in the system. You've talked about systemic inquiry. So you've asked me about weight loss, and you've asked about each of the health systems. And actually, if we go back here, that's set out pretty well. And oh, this particular document doesn't have it, but some of the documents will have, for each of the health systems, some key questions. Anyway, and then you've asked me about my ideas, concerns, and expectations, and now you're touching into past medical history. Now, in practice, I have never, when I've clerked a patient, gone through the past medical history in extensive detail in its entirety. Why? Because if you look at the vast majority of patients that come through acute medical receiving, they will have uh, literally hundreds of clinic letters, literally hundreds of contacts with the health system. And if you were to go through every single time that they had seen their GP about a bunion, you would not be able to provide them with the care that they need. So the key things are that you need to know where to look in recent referral letters and things for the key things in their past medical history. You need to be able to go through their medications and ask them relevant questions about the past medical history in relation to what they're currently taking. And you need to ask them about their past medical history in relation to what's brought them into hospital. So if somebody's come in with abdominal pain, you need to ask them, what surgeries have you had? Um, did you have a general anesthetic? Did you have any reactions to the general anesthetic? If there's somebody that's previously been pregnant, you need to ask them about, and they're potentially for surgery. You need to ask them about whether they had C-sections, whether they've had, how many pregnancies they've had to term, and how many just gestations they've had. And you need to ask them questions that clarify things that you might not understand after having done a review of the records. So the next thing you do is drug history. Are you familiar with the term medrec, Mohsen? Have you heard that before?
I have, but I can't remember what it stands for.
Yeah, so it's medicines reconciliation. So I'd certainly not properly understood it before I started working, but what it involves is you've got a list of all of the patient's medical records in the system, and one of the advantages, at least, of um, working in the NHS is if a patient stays within the area of their trust, often you'll have records from years and years and years detailing what's going on with them. If they've come from a foreign country, if they've just flown in after having lived in Thailand for 15 years, it's a lot harder to understand what's been going on with them than if
Is
you
that
have the record.
similar to the KIS, the key
So
information?
the key information summary, in my experience, or at least the way it is in Glasgow and Great Clyde, is that generally outlines, for example, whether they're on the palliative care register, what diagnoses that they have, whether they have community DNA CPR. Um, I don't think the medications are on the key information summary. But anyway, often it's like ECS and KIS, the meds and the key information summary are sort of two bits of the same system. But anyway, so you've gone through their medications and then you reconcile what's on the system with what they say to you, or what medications they have, or what their carer says to you, and you get two pieces of information. You cross-reference the two, and you prescribe medications for while they're in hospital. Um, and it's also important when you're taking that drug history, of course, to ask about allergies, to ask about any recreational drugs, to ask about whether they drink. Quite a lot of people drink enough that when they come into hospital, they are at risk of withdrawal. So it's important that you have an approach to that. And certainly in Glasgow, there's the Glasgow clinical alcohol withdrawal scored clinical alcohol GMOS, no GMOS. So Glasgow Medical Alcohol Withdrawal Score. It's GMOS. It's called GMOS in GDC, and that yeah, it's important to know if your patients drink too much. It's important to know how much they smoke, and how long they've smoked for. Um, and certainly, it's important to take a social history, not just in terms of um, family past medical history. That's not always relevant. What's perhaps more relevant is, do they live alone? Is there somebody that can watch them post-operatively? Are their children still at home that may potentially need care? Or if they're very unwell, do social services potentially need to be involved? Um, are they at risk of occupational exposures? Respiratory medicine and infectious diseases probably are the two best, I think, in terms of how in-depth they go into people's occupational exposures. The number of occupational respiratory diseases that exist is mind-blowing. So certainly if it's a patient that's come in with potentially occupational asthma, your approach to it will be far more exhaustive than it will be with somebody that's come in with broken toe.
I think I had an experience at a placement once where this old lady came in and she was just fainting all the
Right.
time. And I think at the end, just by chance, really, the doctor likes to take the credit for this, but honestly, it was just by chance. She mentioned she had stairs in her
Yeah.
house. And just thinking about that situation, if that didn't pop up, so then we called social services. They came in, they fitted in a lift chair and
Yeah.
different thing because we were deadly worried in case she's walking down the stairs and she.
Yeah, absolutely. And one of the things that I think, again, my experience has been very limited, but I I I definitely think the access to physical therapists and occupational therapists in the NHS, because it's, there's this sense of an obligation to care for your patients once they go home, and is is it, I've always had really good experiences with occupational therapy and physical therapy is what I mean to say. Certainly patients often have to wait a very long time for social care, and the fact that patients have to pay for social care is not good in my view. But the fact that there are occupational therapists that are willing to make assessments and do the actual real important things like getting patients back home is so good, because you can play around with somebody's fluid balance and the medications all you like, but at the end of the day, what matters to people is can they get in and out of their house. That's far more important to people than whether their dose of diuretic is perfect or whether they're on exactly the right second line asthma medication. So that's really important. It's really important to take a good social history, and it's really important to ask about functional status. So, Mohsin, what is the one question that you would ask to assess somebody's functional status?
Kind of putting me on the spot here, aren't you?
Yeah, no, I mean, it's completely fine.
um,
I'm very bad at talking to the ether, so I'm
yeah,
glad
yeah.
that I have.
I think if I want to understand the functionality, I would really ask what they. I mean, I think one of the questions when I was doing my GP placement was,
Yeah.
can you do the shopping by yourself?
Okay, that's a really good one. That's a really, really good one.
So if
What
they
the
can't do the
question?
shopping by themselves, it's most likely like they're really, really struggling
Yeah,
even for nutrition.
that's very, very good. The question that I typically ask is this one. It's on a good day on the flat, how far can you walk before you have to stop? And that's perhaps slightly ableist in that if people are in a wheelchair, they might actually be functioning quite good, but not able to walk very far. But that's the question I ask. On a good day on the flat, how far can you walk before you have to stop? And the follow-up question is, why do you have to stop? And I went to uni in Edinburgh, and the way you could get people to measure it if they weren't sure how many meters was you'd ask them, well, if you start on Scott's Monument on Princess Street, what shop would you get to before you have to stop? And if they got to the KFC, they weren't so good. If they could get all the way to the McDonald's on the far end, they were doing pretty well. So, um, if they could get to Lothian Road, they were doing pretty well. So anyway, so that's really important to understand somebody's functional status. And if they tell you that they can walk any distance, miles and miles, the next question I ask them is, could you run up a flight of stairs? And that's important because if you've documented that clearly, when somebody's come into hospital with a mild exacerbation of COPD, it's really important for the ITU reg that's seeing the patient at 3 in the morning, 2 weeks later, when they develop the HAP and they're thinking about whether intubating this patient may or may not be the best thing. So it's really important that you get this information when somebody comes into hospital, that you clark these key things, that you document these things in the clarking clearly. And yeah, that is that. I'll tell you a funny wee anecdote from this last week of work. So I was clerking in a patient that told me that he could walk. His functional status was on a good day on the flat, he could walk 10 feet holding his wife's hand. Um, and the reason he had to stop was because of instability. And this man's signature was like that. He was he's being currently investigated for a movement disorder, possible Parkinson's. And I asked the man, sure that I would know what the answer was, whether he still drove. And he said yes. Should I stop? So don't assume anything. Don't assume anything. And it's really important to also know whether patients drive or not. It tells you a little bit about how independent they are with things. Um, And it also tells you potentially about the chronicity of what you're seeing in front of you. Because if somebody in front of you is unable to get out of bed and go to the toilet, but tells you that they were driving 2 days ago, that's a very different situation to somebody that hasn't driven for 10 years because, um, their memory and their coordination haven't been good enough. So just as it's often a rite of passage for 18-year-olds to start driving, it's sort of a rite of passage as well for people in their 60s and 70s to stop driving. It's often a big milestone and when they start to lose their independence. So anyway, it's worth asking about. Cool. So the last really main bit that I'm going to talk about is confidentiality. And again, I'm going to return to the GMC's guidance on this. And there are some key principles in how you should handle patient information. You should use the minimum amount of personal information necessary. You should know how to manage and protect information. What that means is you should use hospital electronic systems. You shouldn't be putting it on unprotected USB drives. You shouldn't be putting non-anonymous information on your computer. And you shouldn't be leaving handover sheets on buses or even taking them home, ideally, though I think the reality is you'll find very few junior doctors that haven't accidentally taken home a scrap of confidential information at some point. The key thing is to be candid and to go back as like the next day and put it in the confidential waste bin or return back to the hospital if that's practical on that day and put it in the confidential waste bin if you're not miles away or if there's potential of that confidential information being disclosed. And you need to be aware of your responsibilities. So you are responsible for any confidential information that you have. Once it's in your possession, especially if it's a physical document, it's your responsibility. You're not going to leave it on the lunch table. You're not going to walk away from a restaurant and leave it somewhere like that. That's just unacceptable. You need to comply with the law. And we'll talk a little bit more about how the law relates to disclosures and breaking confidentiality. And you also need to be able to share relevant information with your colleagues for direct care when necessary. And that's not just doctors, that's allied health professionals as well, of course. Where practicable, you should ask for consent, either explicit or get implicit consent. And we'll talk a little bit about those too. And you should tell patients if you're making a disclosure. If the gentleman that I described who was being investigated for a movement disorder, he told me that he would stop driving. He told me that he would stop driving and he had an appointment in movement disorder, and that he'd be given advice about it very shortly. If he had told me that he was not going to listen to me and that he was going to continue driving, I would be forced to disclose that to the DVLA, and I would be forced to tell him that would be what I was planning to do. If you're making a disclosure, you should tell patients about it. And the final bit is that you should support patients to access information. So patients don't automatically have immediate access to their medical records. They can't necessarily look through the records themselves if they want to, because there can be confidential information about other patients. There can be confidential information about, for example, family members. If you know that a patient's father has Huntington's disease, it's relevant to their medical care for that to be in their medical records. But if the patient's father isn't willing to have that information shared, that's a more complex discussion, and different people will arrive at different conclusions about what they think the best thing is to do in that situation. Certainly, I'd have to look into the case law to understand what the best thing to do in that situation would be. But the bottom line is that you cannot just give patients their own information without thinking about what the implications may be in terms of confidentiality of other patients. Okay, so when can we disclose information? If a patient consents explicitly, for example, for teaching, if the patient that I spoke to about last week had explicitly consented that I could share de-anonymized information about him. I could share information that would allow him to be identified. You don't know the ward that I work on. You don't know where I was working last week. So it would be essentially impossible for you to identify that patient. And you know, it's implied that if a patient seeks medical care, that information will be shared with the rest of the medical team. So implicit consent is something we work off quite a lot. If a patient tells me something as an inpatient, they know that I'm going to share that information with their nurse, that I'm going to share it with other doctors and with the consultant. And it's similar for audit as well. If we audit a health system and how we're doing in terms of managing a particular group of patients, there's implied consent that we can use patient information for that purpose. We can also disclose information if we judge it to be of overall benefit for a patient lacking capacity, and there's quite specific GMC guidance with regards to what that means. I advise you to look at the GMC decision-making tool on the website if you are in a situation where you're not sure what exactly to do. But a classic example would be a patient that comes into the ITU, is intubated and ventilated, and it's generally considered their overall benefit to share information with their next of kin about their progress, unless they've explicitly said, no, don't share information with this person before they've become unable to make decisions. And there are certain statutory requirements under which you may have to share information. If a court of law, for example, says you need to share information about whether this patient had a high blood alcohol when they came in after a car crash, you need to share that information. And there's other specific case law about when you can or can't share information. So for example, there's law around confidentiality in assisted reproduction. So patients undergoing IVF are protected under specific legislation. And certainly if something is ruled to be in the public interest, so if a patient says, I'm going to go and kill somebody or stab somebody, it's in the public interest for you to disclose that information to the police and disclose that information to the person that's at risk. In situations where somebody isn't at risk of death or serious harm, the advice from the GMC is to seek legal counsel as to whether you can share information or information from the Caldecott guardian, which is the local guardian of confidential patient information about whether you can or can't share that information. There's that decision-making tool there at the bottom. And here are some more specific bits of guidance from the GMC. So you need to contribute to confidential inquiries. You need to contribute to adverse event reporting. There was an example of a patient that I was involved with a couple of weeks ago who had an adverse event in association with quite commonly used drug. So a yellow card disclosure was made stating that there might be an adverse event associated with that drug. And similarly, if an organization asks for information regarding a particular potential exposure, for example, if Public Health England is examining the link between a particular chemical and a particular outcome, you should share information with them, but you should try and keep it confidential wherever possible. Okay, so that's a bit about confidentiality. Again, I give the disclaimer that I'm not a lawyer and I'm a very, very junior doctor, so take everything I say with a big pinch of salt. This is the final bit of this talk. Here are things that I wish people had told me when I started being an F1. So the first thing is keep a jobs list. Have a list of all the patients that you're responsible for when you're in hours, and have a little blurb about what's going on with them. Know what team they're under, especially on a surgical ward. There will be 4 different ward rounds a day, potentially. You need to know who's been seen, who hasn't been seen. You need to know what needs to be done in terms of scans and referrals and whatever else. You need to vaguely know what's going on with each of them. Write everything down, because nobody in the world has a good enough memory to remember 5 things about 20 people that have never met before, and remember exactly when to chase scans and things like that. Out of hours, I think something that's really important to know is There's not that much that you can do as an F1. You can take a history, you can examine a patient, you can do an ECG and take bloods and do a gas. And then once you've gotten that information, you can make a basic plan in terms of whether you want to request any x-rays, give the patient antibiotics or fluids or electrolytes or insulin or analgesia or antiemetics. But there aren't that many other things that you can do. There are a couple of situations where patients are sort of emergently unwell, for example, seizures or urgent hypoglycemia where you need urgency, but often there is time for you to get some information, make a sensible sort of plan and draw some sensible conclusions, and then do what your real role is, which is to know where to get more guidance. And definitely don't work beyond your competencies. If you feel like a patient is quickly deteriorating, or if you feel like a patient has something going on that you don't fully understand, you should ask for help. But if it's a stable patient, get the initial information, request the initial scans, take the bloods, and then contact your senior. The final bit I'd say is just try and be nice to people. It's not easy being an F1, and it's very easy to be rude. It's very easy to lose your patience. God knows I've lost my patience so many times over this past year, but it does get easier, and it's really important to try and be nice to people as much as you can. And similarly, don't take it personally if people are ratty with you. You know, this surgical red that slept 4 hours in the last 2 days. I'm not saying that you should accept bullying or abuse, but often you'll be in a situation where somebody will be ratty with you, and you know what? Uh, it could have been a volleyball with a face painted on it, and they would have gotten the same abuse. So don't take it personally because people are struggling in ways that you might not know. And yeah, just do your best. So that's it for me. I think we can probably move on to the Q&A then, Mohsen.
Yep. Thank you so much, Dr. Parajuli. That was enlightening, honestly. It was really good. Great job. And I think before we move on, I am just going to take over the screen sharing and ask you all to please fill in this feedback form. So you guys can use this QR scanner scanning code over here. So just open your camera app, point your phone at it, and magic happens. And before you know it, you have a feedback form in front of you. Alternatively, what I will do is if you guys click the Q&A at the bottom, you guys can see the answered questions. And in about a minute, I will just post the feedback form over there. So I'm going to move on quickly to the questions. So I think the first one I actually should have asked earlier, and it's quite an important one, which is what would you say to a patient or a family member of a patient who insists on only discussing the matter with a consultant?
Yeah, so what I'd say to them is, so my role is to initially ask some questions and get some information. Um, yeah, I can discuss things with the consultant, and the consultant will eventually see you. And I've never come across a situation where somebody has refused to give me an initial history or initial amount of information, um, and insisted on speaking to the consultant. I've never come across that. And it could be that somebody doesn't accept your plan and they want to speak to the consultant, uh, which is fair enough. I can understand why somebody wouldn't be fully confident in my plan, having been a doctor for a grand total of a year. But the important thing is that you say to them, well, okay, that's fine. Consultant will eventually come review, uh, and you know, this is what we're planning on doing in the meantime. And people in general are reasonable. I mean, people in general, I've not come across people who are like, I need to speak to the consultant right now. I have heard about these kinds of patients and these kinds of families, but in general, you know, I think people tend to be fairly reasonable. I guess if somebody's really, really worried about a family member, I suppose I could understand why they'd want to speak to a consultant sooner rather than later. But especially if you're working in an acute receiving unit or something like that, I mean, they probably will get to see a consultant within 24 hours, or certainly a senior registrar. And I guess maybe I've been spoiled a bit in that I've worked in the Queen Elizabeth, and patients do tend to get seen by a consultant every other day. Um, so I don't know. I suppose what I'd say is communicate your situation with them, document everything clearly, and say to them, is there anything specific that you're worried about? Is there anything specific that you want to discuss with a consultant? How can I help? And be candid about the limits of your knowledge and say, well, we don't know that. And it might actually be that it's appropriate for you to seek help from your consultant because they've said, well, actually, my family members developed this symptom and I'm worried about X, Y, Z. Um, but it might well be that they just want to chat with the consultant and you can just say, that will happen, but it won't happen right now. So just be honest with them about how you view the situation and what, you think is going on. I think just be candid.
Absolutely, I couldn't agree more. Just before I move on, so the feedback form link is in the Q&A. So if you click on the Q&A, you guys should be able to see an answered question, which has the feedback form link on it. Guys, I really encourage you to fill in feedback form because it's the only way we improve. And actually, we were having this discussion the other day in regards to our journey from January till now, and it's honestly just because of feedback. So give Dr. Arun Parajuli all the criticism you want. He loves it. He loves it.
Yeah. I love it. I love it. I love it.
Actually, in regards to the point you made with the first question, I think that's just so that it's a typical thing we come across because you don't just see it in medicine, you see it everywhere, even like restaurants.
Anywhere with
I want to speak to the
customer
manager.
service, you
You
realize.
always get that one person, I want to speak to the manager. So I think our consultant is that sort of equivalent where they're like, I want to
Yeah.
speak to the consultant.
Yeah. So, I mean, sometimes it will just be a matter of, I understand that this is the timeline for how these things happen. This is what's going to happen in the meantime. And if they're unhappy about it, that's fine. As long as you document what you do and you're polite, respectful, and explain why things are the way they are. At the end of the day, if they make a complaint, it's not your job to deal with
Yeah.
an unwarranted complaint against you. If you've documented, especially if you've documented this patient was unhappy because of this, um, and you should absolutely document any aggression against you or any abuse. Um, if you document things, you're protecting yourself, and you're also protecting the patient because you are explaining exactly why you've arrived at a particular course of action.
Absolutely. And I think one thing my brother even expressed to me quite importantly so is know your rights as a doctor. Like you are allowed to say no. If situation is getting out of hand, you are allowed to take a step back and not have to deal with it. So
Yeah.
there are people to do that. And it doesn't have to always be you in the middle of the Mickey Mouse operation. You can stand back and say, I'm not qualified for this, and I've not got the training for this, and I'm not dealing with this.
Yep.
So the next question,
But the key thing is you always need to make sure the patient's safe. I mean, you can't just walk away. You can't just walk
yes,
away.
yes,
You
yes.
need to act within the limits of your competencies,
Yeah,
and you
but
need to do the
even
things.
primary survey, doctors ABC, the first thing is danger, and if you feel
Yeah.
like you're in any sort
Yeah.
of danger,
Absolutely.
yeah,
Absolutely.
step back.
Absolutely. Absolutely.
The next question is, I think, really to do with in regards to patients' consent for using their information for public interest or preventing or finding a solution to a disease or disorder. So I think that's in regards to using it for research. So how would you get around that?
Yeah, so there's a couple of different things here. I mean, so the first thing is if it's uh for audit purposes, for ongoing quality improvement within a system, there's implied consent, or at least the you know medical law within the UK. At least my understanding of it is that there's implied consent that your anonymized data will be used for audit purposes. And for research, you need consent, you need ethical approval, and often you'll need patients to explicitly give their consent, particularly if it's not anonymous. Um, so that was the research side of things. But I think there was also the question kind of pointed at maybe um, public interest, so communicable diseases. Um, and there it's difficult. It's very difficult. Let's say a patient's come and told you that they have, you know, been having unprotected sex with somebody and they've got HIV. There is thus significant risk of um, serious harm to their partner. And I know of a registrar that was in exactly this situation with a patient with a very serious communicable disease and their partner. They did not want their partner and their partner's family to be told about their illness. And I think what ended up happening was they sought legal advice uh, and they were told that they could actually make this disclosure. So I think the key thing really is that you need to do something. You cannot just ignore the situation, and you need to seek legal advice. You need to escalate things. Certainly, it is not your job to decide whether or not to make the disclosure, but it is your job to seek advice. It is absolutely your advice to escalate things. And it's not your job to solve the problem, but it is your job to escalate things.
Absolutely.
Unless you're a consultant that's watching this talk, in which case
Yeah, I was
you're
just about
wasting
to
your
ask.
time. Don't listen to this.
I was just about to ask because it's like, I always wonder what it is because private hospitals in America and other countries, they have their own legal teams on standby. But what's the situation with the NHS in regards to that? How do you guys actually
Do you
go
know?
about
I don't actually know. I don't actually know. I think, I mean, certainly on an individual basis, if you have a concern about information as a medical practitioner, you can contact your defense union. So you should have insurance through some sort of medical defense union
MDQ
as a
or
doctor.
uh,
Well, yeah, without naming any of them, you need to have some sort of membership. So um, I've had one situation over the last year where I've sought legal advice about something. And it was because of a situation on a night shift where a nurse gave a patient a drug that had not been prescribed, and they ended up going into peri arrest. So I ended up calling my medical defense union at 3 in the morning. But I documented very clearly everything I did, and I reported it through the clinical incident system. And I think anybody that looks through the records can see my point of view very clearly about everything that happened. And
uh,
nothing came of it. The patient was completely fine. But
okay.
patient was completely fine. A bit of naloxone and they were fine.
Okay.
But yeah, if you're ever in a situation where you want legal advice, you need to document everything really clearly. You need to be really candid. You need to be really honest. The first bit of advice I was ever given by my supervisor, my first day working on in the NHS, was that people in the NHS are not fired for being slow, and they're not fired for being incompetent. They're fired for being abusive, and they're fired for lying.
Yeah.
So you can be grossly incompetent, and you will find some failing NHS trust that will hire you as a doctor if you're qualified to work in the UK. The important thing is that you do not work hugely without the limits of your capabilities. So you're not trying to put chest drains in as an F1 who's not been trained in it. And that if you do make a mistake, that you're candid about it, honest about it, and that you've documented everything. And that you're not abusive to people, you're not discriminatory, that you're not rude, because that will get you sacked, and rightly so. But being slow, being bad at your job, probably won't, because there are lots of people, like, there's going to be a certain proportion of people that are just bad at their jobs. Maybe it's me, maybe I'm bad at my job, but there's a certain proportion of people that are bad at their jobs. But as long as you're honest and as long as you're not abusive, you'll probably be okay.
I think that's actually a big concern for actually probably most of the students watching this webinar right now, because a lot of us are trained abroad and we go back into the NHS system as doctors. So we have very little exposure to the system itself.
Yeah,
And, a lot of people are worried like, oh, I'm not going to know what I'm doing and I'm going to lose my job. And I always try and explain to them, because I have a tiny bit more exposure, and I always try and explain to them that you won't lose your job because you won't know what you're doing, but you lose your job because you're doing something wrong. And
absolutely. If you actively act out with your I mean, there's probably a certain portion of people. Let me put it this way. Let me put it this way. So you've passed medical school. Um, a person's passed medical school. Maybe the medical school that they went to was actively fraudulent, and the exams were easy to an extent where the person passed, but they are just never going to be able to be a competent doctor in any capacity. I think that's far less likely than this person's actually capable of doing the job, but they've made a mistake and then they subsequently hide it, or they're abusive, or um, they are acting out with their capabilities. So they're acting as an SHO when really they should be acting as an F1, or they've taken a job as a registrar where really they should be working as an SHO. Or there are other things in their lives that are making things harder for them. And definitely it's not easy being a junior doctor, but I think, the key things are that you do not work out with your capabilities, and that you are honest, and that you seek information, because you can't know everything, but you can know the limits of your knowledge and seek information where you don't know things. So, oh, and don't do what an IMG that I worked with on a weekend did, which was get the WhatsApp number of a patient and start WhatsApping him, taking pictures of him playing his guitar to her on her phone and upload them to Instagram. That's a no-no. Don't film. I'm almost shocked that I have to
It's a
say
rookie like that. That is
yeah,
a rookie mistake.
but I mean, people are sensible. I'm sure you guys are all sensible. And
Yeah.
so,
Again, that's all it really is, because, working in different countries, they have different levels of strictness with these sort of barriers and these rules and the red tape. And, that's something I always tell people who are going back, because they're still digging their head deep into, books, which is not a bad thing to do, be up to date with your clinical knowledge, but it should be like, good medical practice. You're reading tomorrow's doctors, things
yeah.
like that. No,
I mean,
no.
at the end of the day, end of the day, uh, like you go through medical school and you learn 15 different causes of glomerulonephritis. How many times have I used that over the last year? Zero, zero. All you need to know how to do is do an A through E, prescribe fluids, prescribe insulin, prescribe analgesia, do an ECG, read a chest X-ray, interpret an ECG, and read and write. That's about it. That's about it. It's I sometimes I almost feel like medical education is a scam, in the sense that when you start out as an F1, there are very few things you actually need to know how to do. You just need to know where to look for more information,
Yeah.
and you need to know how to be organized. So if you're like to be candid with you, I spent a lot of time in medical school studying, and when I graduated, I could list 15 causes of glomerulonephritis, but the people that couldn't were much better F1s than me, because they had other skills, because they were better at organizing themselves, they were better at working faster, they had spent more time on the wards. Uh, does that mean that they will always be a better doctor than me in every way? I don't know. It's probably not up to me to judge. But the bottom line is, just because you've memorized Davidson's, or your anatomy in and out, doesn't mean you're going to be a good doctor. What makes a good doctor? I probably don't know either. I'm not qualified to say, but it's not memorizing things. It's probably more about um, knowing where to look for things, and being
Absolutely.
a good listener and having good people skills. That's probably far more important.
I think I just want to point out that somebody actually put in a comment that's very reassuring. And it really is, because, I
Yeah.
think a lot of the people I talk to, even people in years above me who are just about graduating right now. And I think the main thing I've noticed is it's a confidence thing and it's a mental thing. And I think that's just with everyone. If you graduate from Oxford or Glasgow or India or America, wherever it is, you're always dreading that step from going from
Like
studying to
the
work.
thing is, do you really think that a consultant in general medicine will know every uh every first line antibiotic for every infectious disease topic. Absolutely not. They absolutely will not. The key thing is that they know where to refer patients. They know where to find information, and they have clinical experience. You know, it's not about actual necessarily knowledge. It's about knowing where to refer things. And the best ones, at least that I've seen, do have a hell of a lot of clinical knowledge as well, more than I'll ever have. But uh, there are still damn good ones, you know, that have been working for a long time that probably still aren't up to date with a lot of things, but they're sensible and they know where to look for things.
Mhm.
Um, anyway, this is an F1's opinion, so
Yeah, yeah,
really take it with a big pinch of salt. But the,
yeah.
the point that I'm making is that clinical knowledge is one thing, and being sensible and knowing where to look for information is another.
I don't know what is common sense even, but like,
Yeah.
well, I think
Not that I have much common sense, so that doesn't save me either. But
that's,
anyway,
I
does
actually
anybody want to demute themselves and just ask questions?
sure I can do that.
Yeah,
Where is my participant list? I think you guys can raise your hands and I can try and unmute you if someone raises their hands. Has everyone filled in the feedback forms? I hope you all have.
please.
Please, pretty please. Okay, somebody raised their hand, so this is good. Let's see who it is. Okay, I'm just trying to figure out how to check this. I'm just going to stop screen sharing for a second so I can make sure I have this here. Okay, so nobody raised their hands. Okay. Oh, no. Hajira? No? Okay. Never mind. I think actually somebody messaged me halfway through the webinar asking me to ask you about a little scenario me and him came through. And it was actually from one of the medical defense unions who send out certain situations that have happened. And it gave us the circumstances without the answer. So we were kind of curious about it. It was actually a junior doctor who had, like you said, some details of a patient scribbled down on a piece of paper.
Yeah,
I think at the end of her shift, or I think maybe it was lunchtime, she went to her locker, got something. Anyways, when she was walking out of the away from her locker in the hallway, that little piece of paper that wasn't relevant anymore dropped out of her back pocket. Now she went to go for lunch and she was sitting with her friends having lunch, and only after her lunch finished she noticed she didn't have that in her pocket, so she went and reported it. But she reported it, I think right after she dropped it, somebody found it, picked it up straight away and gave it to the reception.
yeah.
And between her losing it and it getting handed in by someone else and her reporting it, it was good, I think, over an hour, a couple of hours.
Mhm.
So we were really trying to discuss the severity of the consequences she would face for that. I thought it wouldn't be too major. My friends disagreed.
So is the question what would actually happen in practice to this person?
I mean, how many? I mean, did she really do something wrong? There is,
Yeah, she did something wrong in the sense that it was exactly what we were talking about earlier
yeah,
about knowing your responsibilities. It's her responsibility if she's got confidential patient information to protect that. So she absolutely did something wrong. And and I mean, it really depends on what the information was. You
yeah.
know, I I don't know. I don't know what exactly I would do in that situation. If it
This
was
is,
literally just a patient's name written down on a piece of paper or a patient's initials written, if it was a patient's initials written on a piece of paper, I think it'd be a
I
very
think it
different
was the
approach.
patient's full name, and I think beside it was maybe a procedure she had to do, or
Okay.
it was
Yeah.
basically, the thing was is she didn't need that piece of paper anymore. She was intending to throw it in the bin.
Really the best case scenario, I mean, really the most honest thing in that scenario would be for that person to speak to the patient probably and to be honest about what's happened.
Yeah,
And
but that's a lot of patience.
it's that's very it would be a very very difficult situation. It would be a very difficult situation to find yourself in. Um,
Yeah,
but I think in terms of your duty of candor to patients and your duty to reveal to patients when you make mistakes, I think it would be entirely the best case scenario would be that you would say to your patient, look, this is what's happened. I'm very sorry. And I completely understand if you want to make a complaint. Um, these are the steps that I've taken to make sure this won't happen again. I think the practical reality is this is a situation a lot of people could find themselves in. But yeah, it is very serious. If a patient has a diagnosis of a potentially sensitive disease that's written on a piece of paper and it's picked up by somebody else, this could have very serious consequences for the rest of their life. So it's not something to take lightly. Confidentiality is very important.
It's a tough one. It really is. I mean, I think we were arguing about this for a full hour before we
Yeah,
decided, okay, because I felt like she did something without knowing, but then again, my friend explained it, you walk into a shops, you tip something over by accident, you still pay for it.
yeah,
So
absolutely. So I mean, do I think that this person would, be properly struck off? No. Do I think it could potentially lead to a GMC referral? Yeah, I think it could actually. If the patient wanted to make a GMC referral, and if they just had a medical termination of pregnancy and they wanted to make a GMC referral, I think they could.
yeah.
So I don't know. I don't know what the consequences would be.
Yeah, it's honestly a tough one. I think that's the thing in terms of, I try and come across these cases as much as I can. Not that I hope to do mistakes in the future like this, but in case if I do, at least, for me, in my mind, that situation, it's so minor because I'm just like, oh, I dropped a piece of paper and what, somebody handed in, nothing happened. But when you find out the realities of it, that could be something, quite severe and detrimental for your career. So, I think it's always good to obviously go through these scenarios as much as you can. And I actually had someone asking how to do that. And personally, for me, it's websites like medical defense unions that I
Mm.
go to, and they have a lot of these scenarios there. Is there any way you particularly prepared for, being a junior doctor that didn't involve clinical medicine, but more so, this is what I need to do and this is what I don't?
Sorry, do you mean need to do and don't in terms of what? Sorry, exactly.
Just your sort of guidelines in regards to, okay, confidential, like the way you learned everything.
Yeah, so actually, the way that I learned it was firstly, we had a sabbatical teaching at university, which talked about some basic medical principles and some elements of medical law and ethics, around confidentiality. The second thing is when I sat the SJT, I looked through a lot of this stuff again. And so if you come back to the UK, you'll have to sit the situational judgment test. I think that's still a thing for foundation.
Um, Surprisingly, we don't have to do it because
Really?
as soon as we come back, at least from my side, it's coming from Bulgaria. As soon as
Okay.
I come back, because I will be fully registered as soon as I register with the GMC.
Really?
So, but the funny thing is I'm still studying for it. So
That's good. I think that it's worth having a look through, just to sort of understand the underlying principles and have a common vocabulary with people, you
yeah.
know. Um, okay, if there aren't any more questions,
Yeah,
Mohsin, then
I think that's a wrap. I just want to, first of all, thank you,
no, no, no,
Dr.
no problem.
Arun
Of course.
Parajuli, and I want to thank everyone for being here. So I think this is actually a much better attendance than I expected for August when everybody's on their holidays. So okay, guys, so I'm just gonna call it a wrap over there. Again, thank you all so much for coming. Thank you all so much, and a big thank you to Dr. Parajuli for being here and giving the amazing talk. Everyone, have a great August. Have a great summer. Have a successful research session if you do have research. And I hope to see you at the end of August or somewhere around there. Do take care.